This is actually interesting because it's going totally out of my area of comfort. So volume, I love counting widgets, costing widgets, all very good. So this is going to be an interesting discussion and a movement for Queensland's focus. But, which one? This one? What we really started was, so the focus really is, we initially talked about better value for the money that we're actually investing and published reports that showed where all of our hospital and health services were on a scale comparing each other to the state average and what that might actually look like. And then we always get asked the hard question, how does that compare to the NEP, which is a totally different beast because we have a dual process of funding models in Queensland. But if we look back, we found we had some hospitals that had commonality with the national efficient price, but the publication of the actual reports gave us a little bit of an area of focus and a drive to really be clear and assist, I guess, give a bit of sense of direction about we are looking at what is the cost of delivering services in the organisation. So, and how many and what are you actually delivering across the system. But with the implementation of activity-based funding nationally, with a focus more broadly, there was an elevated level of interest. Queensland's been in the case mix benchmarking space for many, many years and published an annual report that showed the average costs of delivering services. So thank you to ABF nationally, because we've shown that our productivity significantly increased. The focus and area on controlling costs, looking at where the investments were actually going within the hospital and health services. I think there's actually a number of things happened at the same time. So there was a bit of the start of autonomy within the hospital and health services, the devolvement of as much funding as possible out of the department also helped in allowing the movement to actually occur. And we came from an area of having long waiting lists, both in elective surgery and in our outpatients area. So in the time, over the years of implementing activity-based funding and changing to a purchasing focus with a target that was pretty clear, and that there would be benchmarks and a view, not just in the state, but across all states, that we could definitely see a change. Efficiency, tick, but is it what we wanted? So with we were facing, since about the middle of last year, we started to look at, okay, with the end of ABF in 17-18, what are we going to do then? And we looked at options around population-based funding models, and what does that actually mean? Which is tricky when you have some significant investment in specialist hospitals across the state. We're also looking at an era where growth shifts from an uncapped basis, thank you to the Commonwealth for uncapping the growth funding to us, to a capped environment, and therefore demand management would become a key priority. So it was go hard, go fast, do a lot of activity, but then come to a screaming halt at the end of it because we weren't going to get anything post 16-17. So the catch cry of more, well, still works if you have capacity and you can do that at no increased cost to your actual organisation, or your investment is in the areas that where you'd actually need to do it. So what we've seen across our organisations is a real improvement in terms of their efficiencies. A lot of it can be technical efficiency. They've cleaned up the counting and costing of services, but really we're now in a good space to start picking out what are the good things that we're really doing across the state. Which moves us into the area of we've set prices, on some of it on evidence, others a bit loose, I would say. But really now it's our time to look at investing in and our efforts in researching value. And we really like this description of value is what you get. And hopefully our patients and people who interact with our health services across the state are getting or feeling they're getting value from their particular interaction. But value is not a code word for cost reduction. So it's often seen that this is our opportunity to reduce cost. But the defining factor of value is that it relates to expenditure to outcomes. So we're actually going to link our expenditure to outcomes. For the money we spent, what difference did we make? How do we actually evaluate when we spent something? Did we get what we expected for that particular care? And we can see it in the very real access improvements. So where we have seen improved access for care across our state, it's been fantastic. So definitely our investment is working in those particular spaces. But to what did we improve population or individual health outcomes? We're not so sure. So value shifts the focus from what we do, our activities and outputs, to what difference those activities make, as in the outcomes. And a value-based approach is all about the impact that we might actually make in our health sector. We know that education at the moment, if we use that as an example, they do measure by organisation. There's an investment obviously into the resources and inputs, but you get a measure of the outcome, which is the education. If we're looking at my hospitals, there's a whole range of reports, and probably the peer analysis report that actually does show some of the outcomes would be the Staphylococcus aureus bloodstream infections. That one actually does rank or show where the differences are by hospitals. But it's very limited and narrow, I suppose, in its scope in this particular sector. And we'd like to see some more investment in those particular spaces to look at what other outcomes we might be able to measure on a more ongoing and normalised basis. So what does it mean when we're looking at volume-based from activity-based funding to value-based? And that's interesting. Going to PDF, taking all the spaces out of it. So for those of you who have trouble reading that, I've got it down here. So providers make money by negotiating contracts for more services. So we're always looking, as the purchaser of the services with our hospital and health services, looking for more. Please do more with the same money, or actually less, because we've got a driving incentive in the system to find efficiencies. But on a value base, providers make money by delivering results valued by the purchaser, such as health improvement, preventive care, avoidance of unnecessary hospitalisation, efficiency, and quality. I was going to say equality. Equality is a bit interesting. We have lots of arguments between providers and purchasers of what does equity mean, equality and equity across the organisations. But providers focus on episodes and individual interactions under volume-based, but in value-based, we're looking at focusing on populations and the care continuum, incentivising care coordination and integration. And on that particular point, when we're looking at the care continuum and integration, we're really moving from how do we take away any barriers to moving a service from an acute setting and finding value elsewhere in the system. It almost goes back to the original quotation about right place, right time, right patient, right procedures. All those things have got to be in alignment. And is there a choice that's being made by the patient in that particular process? Volume-based, providers see every touch as revenue opportunity, whereas value-based is providers see every touch as an expense to be managed, and it's a really key difference. So activity-based management that's being pushed along is the next iteration, I suppose, from funding. It's actually about where is the opportunity to manage that expense? How is it best invested? Incentivising the provision of only the care that the patient needs and no more. So you're not going to overservice a patient because you really shouldn't, because you need to treat the next person, those type of elements, or are you treating them in the right location? And providers, if we're looking at volume-based, providers inconsistently or crudely apply evidence-based care. In the value-based areas, we're looking at private providers focus heavily on efficacy and effectiveness, including systematic application of evidence-based care together with patient precision. Is this treatment right for this patient? So value forces us to question the relationship between the activity and the outcome and to carefully consider which activities actually make the most difference in terms of the outcome. A value focus therefore encourages focus on efficacy, the potential of a procedure to treat a condition, and the effectiveness, that is, in the real life effectiveness impacted by contextual factors such as intervention effective for this. Is it effective for this particular patient? Should they be having this particular procedure? I was in the Royal Adelaide Hospital a couple of years ago now, I think, not as a patient, but talking to someone, and they were trying to promote a project which was, do we really need to put a needle into the patient all the time? So people come out like pinpricks. So they sort of had a policy, they're trying to get up a campaign which was Stop the Pricks, which I thought was really quite clever. I don't think it flew, I don't think it happened. But it almost was for an awareness session in the clinician's mind about, really, does this patient need to have blood drawn again? Why is that happening? Is it really required? So it's on a very small scale in terms of avoiding interventions that shouldn't happen for a patient. But because there is a clear focus on relationship between efficacy and effectiveness, with the relationship between the intervention and the impact, waste is inevitably reduced because you're questioning the use of the resources. In Queensland, we have practical experiences of, or practical application of incentives where we will actively encourage and pay for interventions that we believe are value for our patients. One of them is discussion, payment for a discussion with patients on advanced care planning, ensuring that people are aware of their choices in their process, and hopefully avoidance of futile care if it's actually not necessary or might be necessary, but the patient chooses not to go down that path and actually understands that they have a choice in that. Another one would be we have a loading for patients who are treated in a stroke unit as opposed to general wards, based on gold standard evidence that a specialised stroke unit positively impacts on patient outcomes. Very rarely has changed what is happening in the outcomes across our hospitals with just these small steps in what we've been doing so far. It's a good start, and we know we're making this shift more and more, but we need to think about how we can organise the whole operating environment so that it enables and incentivises value-based decisions. We need to think about how we fund providers, for example, the opportunities of capitated funding such as population-based funding, potentially at least for specific patient cohorts, such as those with chronic disease. We've been looking at the impact of the chronic disease patients across our system, and of about an $9 billion ABF component in our state, we're looking at about a $2 billion impact in that particular sector. So it's a fair amount of our allocation that goes on. And where we want to encourage non-hospital-based care models with strong focus on preventive health and chronic disease management, and better care coordination, enable people with chronic disease to manage more outside of the hospital. But again, with this and this focus, we're actually encouraging or incentivising the hospital and health services to go and talk to the primary healthcare networks, talk to the NGOs, what's happening out there or what isn't happening out there that needs to happen for the population. And we need to think about provider accountabilities, shifting the focus in terms of accountability for allocated resources to one that is judged on the delivery of health outcomes for a population, and not just the delivery of outputs, so that providers carefully choose the services that they provide, directing resources towards high-value activities and away from lower-value ones. In recent discussions with our HHSs, and as system managers, we're very clear about our role as system manager, and we will monitor and attempt to manage everything that we can, but allowing that accountability to be quite clear in terms of this is what we're setting in terms of our policy, This informs, and policies based on evidence, this will inform our plan, our future planning of health services, and therefore that plan will inform our purchasing profile. So there's a very real link between all of it. At the moment, we've still got, I think, a toe in nearly every camp, and it's a bit of a mishmash at the moment. So in conclusion, I mean, we think the future sustainability of the healthcare system is one of the most significant challenges we're actually facing. We can see that our escalating costs alone are a challenge. Our hospital and health service is going to have a real need to have a real look about what services they are providing in terms of are they clinically effective? Are they providing services that they should be for the population needs? And some of them are just, you have to. They are the only provider in the actual area, as opposed to there are other opportunities or areas that can be directed, the patient can be directed to. So as Michael Porter, widely recognised as the world's foremost expert on value, identifies here, we must move away from a supply-driven healthcare system organised around what hospitals do and towards a patient-centred system organised around what patients need. And achieving high value for patients must come from the overarching goal of health delivery. So we're shifting the focus in the state, and uncomfortable for all of us because we are so used to counting all the widgets, having data, but it's actually now turning it around into how do we make the best use of this. As I said, we have incentives in our system at the moment that reward value or value in care that we've identified under the current evidence. And our current project is looking at, our first one off the rank really is looking at how do we improve the value of care for our diabetes population. So watch this space. It'll be happening over this year. So we'll see some changes for our 17-18 funding model. So we've got some time to actually work that through.